This video lecture is going to start us into Chapter 8 on diseases and disorders of the respiratory system. This first video is going to focus on some of the most common signs and symptoms we see in respiratory disorders and talking about some of the diagnostic tests. When you take a look at the outline and PowerPoint, you'll see how the chapter has been divided into primarily upper respiratory diseases and lower respiratory diseases. And I've organized my lectures according to the 6 major mechanisms of disease that we talked about previously. And so as we're looking through our diagnostic terms and procedures, bear in mind which will be most useful or most applicable to upper versus lower. Now, when you have a patient that you see that you suspect a respiratory problem, on the good side is there's a lot of very easily identifiable signs and symptoms that can give you a lot of good information. We can talk about a patient who is suffering dyspnea, difficulty breathing, or tachypnea, rapid breathing. And this can give us an indication if there's some kind of infection, if there's trauma. There may be some perfusion issue that's causing them to compensate by breathing faster, to compensate with the poor ability to move air in and out. If a patient is coughing, the type of cough can be very indicative of irritation, inflammation, or trauma. And so when you make notes on your patient, you will identify the type of a cough, if it's a dry cough or productive, or if it's hemoptysis. Skin color, and by that we're talking about the perfusion of the tissues. If it's very red or very blue, erythema or cyanosis, this can be indications of if there's a problem with the lungs themselves or with the cardiovascular system. And so if your patient has very flush, very red, all right, there may or may not be a respiratory issue, there might be others, but we do know that at least they are getting oxygen. So that's a good thing. If they're very blue, cyanotic, all right, that tells me that in addition to something respiratory, there may be other issues, and that helps us in identifying where the problems are. We check for fever. We check for aches and pains across the body itself. Those are indicative of systemic diseases. Generally speaking, if it's a quick little acute reaction, if someone has a head cold, they're not going to demonstrate a systemic issue like fever. But if they have something that's whole body, if they've been suffering flu for the past week, or if they have some type of pneumonia, then these will usually present with a fever. For lung sounds, we're talking about listening to the body with a stethoscope, and you can click on some of these links to give you some online examples. I'm not going to test you on being able to recognize any individual lung sounds via sound on a test, but I do want you to understand what it would, how you would describe the sound and what that indicates in the respiratory system. Crackles, wheezes, stridor, and rubs are probably 4 of the most common lung sounds that you will identify clinically in a patient. Rowels is an old-fashioned term for crackles, and rhonchi is an old-fashioned term for wheezes. You do need to know these other terms because they will slip in out of different cases and different references in the textbook. Crackles, that's the one that's going to sound like bubble wrap being rubbed around against each other. It's the mucus inside the alveoli popping upon inhalation, cracking it open. Wheezes is an indication of an obstruction. And so if a patient, for example, has asthma, has severe allergies to the point that's constricting the windpipe, and they have this almost whistling sound as they breathe. Stridor is a high-pitched sound, almost more like a harsh coughing, almost like a harsh, what do I want to say, barking sound. This is usually an indication of a complete obstruction. And so if someone has aspirated food in the respiratory system. Pleural rub, this is a grating sound, usually inflammation of the pleural membranes. Put your hand over your ear, rub your other hand, and that's the sound you would hear. Place your stethoscope when you're the person breathing, you'd hear that rubbing sound. These can be very, very indicative. All right, we break the respiratory system down into the upper respiratory tract, that's nasal cavity, pharynx, and larynx, and then the lower respiratory tract, that's trachea, bronchi, and lungs. Each of these are very different tissues, very different environments, and so they're home to very unique diseases. And so there's two different branches of medicine, one for upper respiratory problems, otorhinolaryngology, an ear, nose, and throat specialist. God help you, yes, you do have to try to spell this, and pulmonology, which is the branch of medicine that deals with the lower respiratory issues. Anatomically, you reviewed through this, and so take a look through some of the details to help you remember some of the major structures, like the sinuses, talking about the pharynx in back here, talking about the thyroid cartilage as a landmark for the front of the larynx, traveling down through the trachea, the bronchial tree, out to the alveoli of the lungs themselves. Helping to diagnose our patient, we have a number of specific imaging techniques, such as bronchoscopy. This is an endoscope that we would push down into our patient. So we're feeding the line up through the nasal cavity down through the pharynx. It allows us to directly visualize upper respiratory structures. We can look for inflammation, infections, trauma, bleeding, tumors, masses, and so forth. We can take a look at fluoroscopy. Fluoroscopy is where we use X-ray to look at the movement of the lungs themselves. We will have you breathe in a radio-labeled gas, and it's a relatively harmless gas. So even, there's a little bit of radio opaqueness to the gas itself that shows up on X-ray. So if there's a blockage, it'd be analogous to an angiogram. We can see the air flowing into the lungs except for this big mass here. That tells me there's an obstruction in that area. We can measure lung volumes and lung pressures, and we can take a look at things like spirometry and oscillometry. Spirometry allows us to measure lung volumes. And so we use a water spirometer like this and allows us to be able to breathe into the tube and be able to see what kind of volumes that we move. Here would be an example of a spirometry graphing. And so the person would start breathing. Tidal volume is the normal passive resting breath we take. And then if we do a massive inhalation, we can fill up our inspiratory reserve volume. And then if we do a full massive exhalation all the way down to the mouth being kicked out, that would be the expiratory reserve volume would be the amount past a normal breath. Vital capacity would be that big breath. So you want to really blow up some big party balloons or blow out all those birthday candles, you're going to move vital capacity, which usually runs about 5 liters. Total lung capacity would also include an extra portion down here called the residual volume. The residual volume is the amount of air you cannot exhale. Just by squeezing your lungs down, there's a certain amount that simply physically you can't squeeze it all the way out. If you like taking the sponge and trying to squeeze every literal last drop of water out, you can't. Just the physical space is still going to retain some. Now, we said spirometry was lung volumes. Oscillometry is measuring lung pressures. And so you put the little device of the kids breathing into the mouth. There's a little clip on the nose. The instructor is showing them to not let the cheeks puff out because that'll mess up the test. Line the cheeks up, and you take a full breath in, full breath out. And the change in pressure over the entire breath can be indicative of irritation, obstruction, poor ventilation. And so valuable tools. We can always do a gram stain. So if we suspect our patient has an infection, viral doesn't do as much good, but we can use the gram stain for bacteria to be able to tell gram positive versus gram negative. We will also see if there's fungi present. The gram stain doesn't tell us a lot there, but just simply visually looking at it helps us to identify. A lot of our pneumonias are caused by unique bacteria, and so gram staining helps us to identify those specific bacteria. Knowing that specific type of pneumonia really helps us with our prognosis. All right, that's the first part of the lecture, covering some of the most common signs and symptoms and the most common diagnostic techniques. Review through the material. Let me know if you have any questions. Good luck.